عمرو على إن هو قدمني بالطريقة اللطيفة دي وذكر كل حاجة. طبعا أستاذي كان في جامعة اسكندرية وله كل العرفان والجميل بتقدمي الحقيقة. Monocyte distribution with. قبل ما نبتدي أحب برضو أقول لكم هنا هو أفكركم ب شوية باثولوجي، هيماتوباثولوجي. white blood cells اللي هم الليوكوسايتس، احنا عارفين ان هم neutrophils واحنا بنقول عليهم polymorph ساعات وهم lobulated. We also eosinophils here in B, which is they having those granules, red granules, and bilobated. The basophils, which they have actually a blue granules. The monocytes, they are very specific nucleus, which is the folded nucleus, and then the lymphocytes. So the circulating, let me show you also the other picture here. So the myelomonoblasts, so all red blood cells come from the bone marrow, as we know. We are interested specifically in the myelomonoblast because those are the mother of the neutrophils, which will be in the blood as neutrophils and in the tissue as circulating neutrophils. The other one, which is the monocyte circulating in the blood, but when it goes to the tissue, it is the mature macrophages. So circulating neutrophils and the monocyte are among the first to respond to pathogenic organisms. Okay, so here we go. So sepsis has diverse and profound effect on all cellular elements compromising the innate immune system. What is the innate immune system? Is the immune system that we were born with. Sepsis rapidly triggers extensive apoptosis in dendritic cell, monocytes, and immature macrophages, natural killer, and myeloid-derived suppressive cell. Also, sepsis causes massive loss and effect also on adaptive immune system. Our adaptive immune system is mainly due to lymphocytes. So there is a massive loss of CD4 T cell, which is the helper T cell, CD8 T cell, which is the cytotoxic T cell, and the beta cell. The Treg, which the T regulatory, we call it Treg in heme, are more resistant to sepsis-induced apoptosis, and consequently, there is an increased percentage of Treg cell in the circulation relative to the other lymphocytes. So monocytes are the key component of the innate immune system response to infection, and they are able to respond to all pathogens type, not only like neutrophils for bacteria, but this for all pathogens type. Despite the advances of modern medicine and acute patient care, sepsis remains the leading cause of death from infection. The incidence of severe sepsis in the United States is increasingly by 1.5% each year. The number of cases documented in 1995 was 750,000, but in 2010 it rose to almost 934,000, and it is predicted to hit more than 1 million in 2020. In 2016, sepsis was redefined as a life-threatening organ dysfunction. This is very important. It's redefined, so they are adding organ dysfunction in it. So now we not only need to know early suspicious of sepsis biomarker, but also early suspicious of organ dysfunction biomarker. So it is a life-threatening organ dysfunction caused by a dysregulated host response to infection. After sepsis onset, the production of pro-inflammatory cytokines, which is mainly IL-beta and IL-6 and tumor necrosis factor alpha, TNF-alpha, by the cells of the innate immune system, mainly neutrophils and monocytes, are result in cytokine storm that produce overwhelming inflammation. So the whole idea is to prevent the cytokine storms by decreasing the inflammation by detecting early sepsis in the treatment. So all this overwhelming inflammation and cytokine storm can lead to blood pressure collapse, coagulation abnormalities, and ultimately organ failure and death. So early identification of sepsis with timely approach and treatment شوية dryness في الهواء.
الصوت راح يا دكتور جيلان.
Okay. Again, highly and early identification of sepsis with timely approach and the treatment remains a major clinical challenge. In 2006, Dr. Anand Kumar, he was my mentor. So basically, we did a study that showed that effective antimicrobial administration within the first hour of documented hypotension was associated with increased survival to hospital discharge in adult patients with septic shock. And then in 2018, only the Surviving Sepsis campaign recommends administration of IV antibiotics sorry يا جماعة عندنا الظاهر very dry here. So in 2018, Surviving Sepsis campaign recommends administration of IV antibiotics within 1 hour of sepsis recognition. So whether infection is suspected is really very subjective from one person to person and has high inter-observer variability. Also, there is something called early sepsis indicator. Early sepsis indicator, it analyzes the morphological changes in monocyte, which can augment the suspicion of sepsis or risk of developing sepsis. So, and this is really very interesting. So, according to the size and the morphology in the monocyte, you can suspect this is going to be sepsis or early sepsis. So early sepsis indicator measure the change in the size distribution of circulating monocytes, known as monocyte distribution width. And this is how we came with monocyte distribution width. Let me share with you this histogram. So this histogram actually, I wanted to briefly review this early sepsis indicator with you, this histogram. So very basically, the monocyte distribution width, or the MBDW, measures the change in the distribution of the volume of the monocyte population as a result of infection. Sure, we will have that because during infection, everything increases, so monocyte production will increase. So we have small monocyte, we have medium size, we have large. It's like the RDW and you have anemia, so there is overproduction, so you have increased RDW. This is exactly what for monocyte. Monocytes are able to respond to all pathogens as type, as I said, as opposed to being specific to bacteria like neutrophils are. So if you see here, the circled population of the cell in the septic patient on the right here are stacking up, you see, up to the end of the, to the top of the histogram, because they are at least as large as that top value. But from this image, actually, we cannot predict what is exactly how large they are. And this is a histogram, representative histogram that I got from actually Beckman culture, the one they have the MDW parameter. So if you see here, this is a non-septic donor and this is a septic one. So in the non-septic donor, this is actually the histogram. And the histogram is correspondent here to the non-septic. If you see the blue line here is the median of the monocyte, and the red line is one standard deviation. So if you compare this one with the septic one, you see there is a difference. This is higher. So in the non-septic, the MDW is 19.1, which is less than 20. And in the septic one, it is more than 20, which is 24.3. And it shows how it is increased in the septic patient. Now, I want to share with you also, this is a study that was done by a group in University of Ohio and Pittsburgh, actually, University. They studied, enrolled a total of 2,000 consecutive adults who come to the emergency department. Again, if you see here, the MBChB alone, it has an area under the curve of 0.78, or I mean 88, which is 0.79. And if you see also on this curve, the white blood cell alone is also, which is the blue line, is 0.5. But if you combine both of them, so not individual MDW or individual white blood cells, but both of them, the area under the curve, which improved to 0.85%. So when these two pieces of information, as I said, were taken together, the ability to discriminate sepsis from other patients with just infection and patients with non-infectious SIRS, which is the systemic inflammatory response syndrome, was improved with an area under the curve of 0.85, as I mentioned. While it is not diagnostic, but this improvement over the individual value, so the combination value improvement over the individual value was statistically significant. So I actually, because of the sepsis and how it is the #1 mortality and how it affects the patient in the ICU, I was chosen to be the leader on actually a study. So the first study that I did, I used the MDW in all patients. So it is, what is the MDW? It is actually a parameter which actually comes when you order the CBC. So we ordered this on all patients who come to the emergency department. And we chose, so to be suspicious of sepsis, the patient with have MDW more than 20 and also with septic criteria. And after implementing this parameter, and this is an abstract that we published, the percent of septic patients identified and treated with 1 hour of arrival at emergency department increased from 8.5% to 5%. Also, accurate identification of sepsis in triage increased from 44.1% to 80%, which is big, actually significance. So appropriate triage prioritizing increased from 50% to 90%. So this actually study, which as I said, it's published, it was with the combination of the antibiotic. It helped us to early identify suspicious of sepsis, run our lab, and give the antibiotic within 1 hour. And it, as you see, it is significantly improved the death and the identification of sepsis. So in conclusion, it is crucial to recognize and treat sepsis as quickly as possible as patients enter the emergency department. Spotting sepsis early is challenging. No single set of criteria or biomarker is perfect, but early sepsis indicator offers a unique approach and will complement other tests. So the combination of the test, as we all know, were tests that we order for sepsis, it's a combination that we have a panel for it, and we order it. Example, lactate, procalcitonin, CBC, etc. And the clinical picture, which is actually combined both of them, SIRS, which is the systemic inflammatory response syndrome, which have the criteria of fever, heart rate, respiratory rate, systemic blood pressure, and including the white blood cell count. And the other one combined with the QSOFA, which is the quick sequential organ failure assessment, which include the respiratory rate, systemic blood pressure, and the acute mental status. So all this together give the septic patient the best chance of survival through earlier initiation of antimicrobial therapy. And this is some of the publication that I used in my presentation. And this is disclosure that I do not have anything to disclose. Thank you very much.
Thank you, Dr. JAILAN, for your very informative presentation. And for the next time, inshallah, another topic بإذن الله تعالى. وللعلم بالشيء القاعة مليانة على الآخر، ودي حاجة من الحاجات النادرة في المؤتمرات اليومين دول، فحاجة تفرح يا دكتور أسامة. قدامك صور الصورة دي والنبي صورها على طول. ها جميلة جدا جدا ما شاء الله. يا ريت تصوروا لها صورة توروا لها الناس الأودينس وهم موجودين. شكرا جزيلا.
دكتور عمرو، بمناسبة السبسز النهاردة في الأخبار دكتور بريزيدنت بيل كلينتون actually دخل المستشفى عنده سبتك برضه diagnosed with sepsis، وادوا له الانتيبيوتيك في خلال ساعة من الدياجنوزس، والحمد لله هو أحسن ونقلوه على أورال وهيروح البيت. So what I want to say, sepsis can affect anyone. Doesn't matter a president or a doctor or anyone, and the most effective way is the early recognition and early giving the antibiotic on time. Thank you. Thank you very much.
Thanks a lot. Bye-bye. فندم؟ فين الجلسة؟ أنا ما أعرفش.